Today we want to look at what can we do, not only to understand and measure and track stigma, but how to effectively address it. And if there's one key question that we can perhaps address is which actions or how can we act to really impact on reducing stigma affecting key populations at scale. In terms of a few logistics announcement, maybe if we can go to that slide. Yes, so please, on the screen you see you can choose your preferred languages. So click on the translation interpretation icon at the bottom of the screen to choose English, French, Portuguese, Russian, and Spanish. And for questions, please use the Q&A box at the bottom of your screen to ask the questions. So I think we can move back to the agenda. Yes, so what we'll do in the next hour is basically look at the evidence first, then go into guidance and practice, hear country practice examples in breakout sessions, and then takeaways from the session and the closure. So the objectives of this session are twofold. We have a slide on this. So first of all, understand the evidence and guidance to address stigma in key population programs. And secondly, really how to understand how countries are implementing stigma reduction programs and what can we do to actually influence and reduce stigma in a way that impacts key populations' experience at scale. First, I'd like to hand over to Anne Stangl, who will actually provide us an evidence overview and works with this US CDC and will give us a presentation on evidence-based interventions to address stigma against key populations. Over to you, Anne.
Sure. Thank you so much, Clemens. And good morning, good afternoon, and good evening, everyone. I'm so pleased to be here with you all today to share an overview of evidence-based interventions to inform or to address stigma against key populations. Next slide. So I would like to begin today by discussing why it's so important to address key population stigma and discrimination. Next slide. First and foremost, the experience of stigma is an infringement on our human right to live a life free from discrimination, as enshrined in the Universal Declaration of Human Rights. Next slide. Secondly, evidence is mounting across the HIV prevention and treatment cascades, demonstrating how stigma, discrimination, and violence are impeding the achievement of 95-95-95 targets among key populations. This slide highlights a few of these studies. For example, under combination prevention, experienced stigma has been associated with lower rates of condom use for transgender people in the Dominican Republic. Under the first 95, a study found that stigma among men who have sex with men and female sex workers in Kenya led to higher odds of reporting delay or avoidance of counseling and testing. From a policy perspective, we can see that laws can either encourage or impede knowledge of HIV status. For example, Kavanaugh and colleagues found that globally, gender-based violence laws were associated with higher knowledge of HIV status. Conversely, sex work, drug use, and same-sex criminalization were all associated with lower knowledge of HIV status. Under the second 95, a systematic review of studies with female sex workers in sub-Saharan Africa revealed a strong association between stigma and discrimination and poor linkage to care, ART, and retention in care. And globally, lower access to HIV treatment for MSM is associated with criminalization of same-sex behavior. Under the third 95, higher internalized stigma scores have been significantly associated with missing an antiretroviral treatment dose among female sex workers in the Dominican Republic and with poorer viral suppression among people living with HIV in Zambia and South Africa. And among trans women in Brazil, lifetime experiences of sexual violence were found to be associated with subsequent reduced likelihood of retention in HIV care and viral suppression. Next slide. According to the UNAIDS Global AIDS Strategy, to reach the 95-95-95 targets, it's critical for countries to achieve the 10-10-10 societal enabler targets. Specifically, countries are striving to achieve less than 10% of people living with HIV and key populations experiencing stigma, excuse me, and discrimination, less than 10% of people living with HIV, women and girls, and key populations experiencing gender inequalities and gender-based violence, and less than 10% of countries having punitive laws and policies. Next slide. So now that we're clear on why it's critical to eliminate key population stigma and discrimination and what the societal enabler targets are, I want to share with you a tool called the Health Stigma and Discrimination Framework. The framework, together with existing data on HIV and key population stigma and discrimination in your country context, can be used to guide discussions with key stakeholders to determine where efforts need to be focused. I'll spend a few minutes on this slide to walk you through the stigmatization process, introduce some key terminology, and discuss how you can use the framework. The framework articulates the stigmatization process as it unfolds across the socio-ecological spectrum in the context of health. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. The first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but they're conceptualized as inherently negative. They can range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health for chronic conditions to social judgment and blame. Facilitators, however, may be positive or negative influences. So, for example, the presence or absence of protective supplies in a health facility can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, such as race, class, gender, sexual orientation, or occupation. Intersecting or intersectional stigma occurs when people are marked with multiple stigmas. And once a stigma is applied, it manifests in a range of stigma experiences and practices. So stigma experiences can include experienced discrimination, which refers to stigmatizing actions or omissions that are prohibited under international human rights law. For example, losing housing because of one's HIV status. An experienced stigma refers to stigmatizing actions that fall outside the purview of international human rights law, such as double gloving or gossip. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with their stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in the framework. And lastly, secondary stigma, which refers to the experience of stigma by family or friends of members of stigmatized groups, is included under stigma experiences. So stigma practices, on the other hand, include stereotypes, prejudice, stigmatizing behavior, and discriminatory actions. The framework considers stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. So these manifestations go on to influence several outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. So now let's get back to how you can use the health stigma and discrimination framework to plan programming to reduce and mitigate key population stigma and discrimination. In terms of where to intervene, ideally, we want to stop stigma marking from occurring. So interventions often focus on the drivers and facilitators of stigma. While we would like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. Next. So as we don't have time to go into more detail today, for those who would like to learn more, I recommend 3 guidance documents. The first, which you see here, is the 2020 evidence guidance launched by UNAIDS. Next slide. And the tools you see here, which were launched last September by the Global Partnership, are also excellent resources for you. So the links to these documents are included in the slide. Next slide. So now let's review some of the evidence-based or evidence-informed strategies available for eliminating KP stigma and discrimination and achieving the 10-10-10 targets. So as I mentioned earlier, it's important to include interventions to address both the drivers and facilitators of KP stigma and the manifestations of KP stigma and discrimination. In the next few slides, we will review examples of evidence-based or evidence-informed approaches to achieve each of the 10s, organized by whether they address the drivers or the manifestations. And links to relevant resources are included in the slides. Next, please. So for the first 10, approaches to address the drivers and facilitators of KP stigma could include KP-led training for health facility staff on KP competent care and stigma-free service provision, KP-led training of police on gender sensitivity, HIV, and harm reduction, differentiated service delivery models that minimize stigma and discrimination, such as KP-led drop-in centers, online interventions, and so on, training for peers to provide psychological first aid to those in crisis, and implementing U=U campaigns. Approaches to address the manifestations of KP stigma and discrimination could include psychosocial support for KPs who experience stigma and discrimination, strengthening referral networks, routine implementation of community-led monitoring and the PLHIV Stigma Index 2.0, also pivoting to a more universal offer of PrEP in high stigma or criminalization areas, moving away from invasive risk screeners to a conversational approach that does not have to identify someone as a key population, and training case managers or other health providers to identify and refer those with mental health issues. Next slide. For the second 10, approaches to address the drivers and facilitators of KP stigma to reduce gender-based violence and inequalities include implementing evidence-based solutions to reduce violence and shift harmful norms, understanding the burden, causes, effects, and circumstances around violence through high-quality data, KP-led advocacy for policies and procedures that prioritize safeguarding KPs against violence, and work with law enforcement to reduce violence against KPs and program implementers. Approaches to address the manifestations of stigma to reduce gender-based violence and inequalities include training providers, police, and other staff on violence-specific adaptations to psychological first aid and integrating these adaptations into PrEP and index testing, ensuring timely availability and access to support services, including post-exposure prophylaxis within 72 hours of exposure, and psychological and psychological support, and ensuring and widely disseminating safe reporting structures, such as the National Crisis Response Systems and National Reporting Mechanisms for Human Rights Violations. Next slide. So for the third 10, approaches to address the drivers and facilitators of KP stigma to reduce or remove punitive laws and policies include community-led evidence-based advocacy with national stakeholders utilizing CLM and stigma index data, routine implementation of the Stigma Index 2.0, the National Commitments and Policy Instrument, and legal environment assessments, developing a national strategy and operational plan for eliminating stigma and discrimination, implementing Know Your Rights campaigns, and routinely informing and sensitizing duty bearers on the legal, health, and human rights aspects of HIV, on relevant national laws, and on the implications for enforcement, investigations, and court proceedings. Approaches to address the manifestations of punitive laws and policies for KP include providing legal information and referrals, providing legal advice and representation, integrating paralegals into health facilities to provide on-site guidance and support for key populations and people living with HIV, strategic litigation, alternative forms of dispute resolution, and policy reform to shift the health and human rights environment for KPs. Next slide. So in closing, I would just like to share a few considerations for ensuring the safety and security of key populations. As you know, KP-led organizations, especially in hostile environments, experience chronic violence and other human rights violations, which negatively affects all aspects of the HIV program cycle. Ensuring data security by all organizations collecting and managing KP data is critical. Based on the context and situation, consider whether service delivery adaptations are needed. This could include expanding virtual or telehealth services, extended dispensing intervals and expanded multi-month dispensing, home delivery services, increased use of self-testing, and increased provision of mental health and psychosocial support to affected program participants and staff. Adaptations may also include the temporary suspension of some interventions or activities, such as group outreach or moonlight testing. And lastly, I encourage you to utilize available rapid response mechanisms when needed. So next slide, and thank you so much for your attention. I'm really happy to answer any questions you have in the chat. Back to you, Clemens.
Thank you so much, and for this very concise and excellent overview of the evidence and really on what can be done to address stigma effectively, including as part of prevention programs. There's a number of strong links to prevention where actually implementation of key population prevention programs can really make a significant contribution to addressing stigma. We'll go now from the evidence overview to a brief synthesis of the available guidance, and I'll call on Dottie Ogutu from GMP Plus, Global Partnership of People Living with HIV, for providing us an overview on available guidance. Dottie, over to you.
Thank you, Clemens. I just want to make a disclaimer before I continue, is that because of time limitations, we will not be able to give you a deep dive onto what Global Partnership does, but I'll focus more on the guidance. But the rest of the information about Global Partnership is available on your slides. Yeah, so next slide, please. Yeah, so I'll pick up where Anne left off, and you'll see that she very clearly mentioned some of these guidance tools in her presentation. So if you click on this on your presentations, you'll actually lead you to the documents and you can download them. But so let me get a chance to briefly explain what are some of these guidance tools. So next slide, please. Okay, yes. So I mean, as part of the technical support provided by the Global Partnership to the countries, there are several guidance documents, as you've seen, and these have been developed in the Global Partnership mainly to help identify and plan in implementation, monitoring, and evaluation of evidence-based and evidence-informed programs that are designed for addressing stigma and discrimination in the 6 settings of Global Partnership. So the new guidance that you see here is a companion of the 2019 and the 2019 rights-based M&E guide and the 2020 evidence guide. So these documents really work hand in hand together, and it's specifically focusing on monitoring and evaluating programs in the 6 settings. So the new guidance supports program implementers and managers at government agencies, NGOs, civil society, and community-based organizations to understand the outputs of their programs and the outcomes of their programs that they are implementing to mitigate stigma and discrimination. And it also helps in improving and scaling up of those specific programs. Next. Yeah. So but I would like to make this disclaimer is that the new M&E guide, so that first document that I just shared, is a practical resource. So in order to understand how this works, you really should be able to to get the detailed explanation that is in the two previous guidance documents, the 2019 and the 2020 guidance documents. I know there seem to be a lot of guidance documents there, but they cover different elements of how you can, one gives you a practical guide and the other one gives you the evidence guide. So the documents are really complementary in how you're supposed to apply them in, in your M&E work. Next slide. Yeah, so a little bit more, and I'm going to focus on this a little bit more on the new M&E guidance, which is designed and it is aligned in harmonization around the 6 settings of the global partnership. So the 6 settings being community, workplace, education, healthcare, justice, and emergency or humanitarian settings. And the context here is aligned with the political declaration, and did mention the political declaration that was adopted at the United Nations high-level meeting in June in 2021. And this is where the societal enablers come in. And so this new guidance aligns each of the settings identified there with the societal enablers, and the implementing organizations are able to select their own output and outcome indicators in this case to understand how their programs are operating and how they could be better improved. And for more, like as an example, you can think around how you collect the data in some of the programs that you're running at national level, your program outcomes for Global Fund and PEPFAR, and you can use that to report on your global AIDS monitoring processes. Next slide. So if we look at this, and then there's this other guide, which is the practical guide. I am aware of my time, which is very limited. This gives you a way to how you can apply the best practices when you're addressing stigma and discrimination. So they might not be specifically talking to key population, but it's a practical guide that can be applied whether you're working with key populations, you're working with women, you're working with young girls, you're working with children. It's a practical guide that can be used to highlight best approaches, and you can use that as a stock taking and a knowledge generating process to understand how you can apply your implementation in a practical manner. And then, and you're able to understand the 3 simple steps. If you move on to the next slide, please. Yeah, so this 3, like it's intended for national, international partners, civil society, duty bearers, law and policy makers, duty bearers in the different settings that I did mention. And if you're able to understand how HIV-related stigma and discrimination do harm, the process of stigmatization, which I think Anna's clearly elaborated in her presentation, and how it manifests and the repercussions of it. So if you're able to familiarize yourself with the concepts around that, and reviewing the 2020 guide, I mean, all these guidance documents really work hand in hand with each other in terms of being able to guide you in terms of your implementation, your practical guide, your advocate's guide. And I will move on to my last slide, which is around the work. Yes. Yeah. And additional tools and campaigns that are run under the global partnership. We have our guides and our checklist there. We have our Not a Criminal campaign, which is really the fundamental or the basis of the DCRIM campaign that we are running as GNP Plus, as the community advocate lead and the global partnership, and other campaigns that we are running around zero discrimination, HIV discrimination, and the More Than campaign around the global partnership. Please feel free to reach out to us. We have our contact information in the slides, and we'll be more than happy to talk to you and give you more information about how we can engage under the global partnership, which some of your countries are part of. Thank you.
Thank you, Dorothy, for this great overview on the guidance. And Dorothy represents the Global Partnership for Action to Eliminate All Forms of HIV-related Stigma and Discrimination. And this webinar is really a collaboration between the Global Prevention Coalition and the Global Partnership, showing that, you know, the aspects that we're discussing here need to be advanced through both initiatives. With that, over to Erika Spielmann from WHO, an active member of the Global Prevention Coalition, for a brief presentation on stigma and discrimination in healthcare settings.
Great. Thanks so much, Clemence. Thanks everyone for being here this afternoon or morning or evening. I will be talking today about stigma and discrimination in the healthcare setting. Can you go ahead and advance to the next slide? And what WHO brings to the table there. So to start with the global partnership that Dottie has been speaking of, WHO is a member of this, and our role really there is the WHO leadership in healthcare settings. So she had mentioned the 5 different settings. WHO focuses again on the healthcare settings. So to start off, to let you know, within our the HIV team, our department is actually HIV, STIs, and hepatitis. So even though we need to keep a broad view on these 3 elements, today we will be speaking more specifically about HIV. So in our global health sector strategy, we have targets for 2025 and 2030 related to stigma and discrimination. Next slide, please. So in addition to the global health sector strategy, the other guideline, and I would like to point your attention to, is the consolidated guidelines for care for key populations. So this is a very rich document. It's focused. It breaks out according to different key populations, actionable drivers, and this is some good practice guidance statements that are highlighted regarding stigma and discrimination. It talks about human rights, the importance of engaging human rights and laws. It talks about importance of collaborating with all level communities, to policymakers, and the monitoring and evaluation that goes along with that. We talk about healthcare services, making sure they're accessible and acceptable and ethical. We talk about training of healthcare providers, and this is, goes all the way from pre-service, in-service, recurring trainings, to educate not only about stigma and discrimination, internal stigma, and to promote non-discriminatory behavior, but also to talk about key populations specific, which Anne had mentioned in her presentation as well. And we talk about services, making sure that they're safe and protected. Next slide, please. This is a schematic from the same guideline that I was just referring to. Again, a very rich guideline, talking about the multi-interventions for key populations and the syndemics. So on the left-hand side, you'll see some evidence around why it's so important to include STIs as well. But as Anne had already referred to, is there stigma? And then, of course, we need to think about all the different elements and the intersectionality that comes with that. So yes, we need to consider laws and policies in the healthcare setting. We need to consider violence, other human rights, unemployment, poverty, gender, race, disability. All of these obviously contribute to the reduced access to prevention, testing, and treatment services. And in addition to that, we need to consider biological and social factors. If we work with one without the other, our success will probably not be as great. So I really like this schematic. Again, you can find it in the key population guideline, the WHO key population guideline. Next, please. So in addition to those two documents I've highlighted, I wanted to just bring your attention to some of the other documents that WHO has. In the middle there, you'll see integration of mental health and HIV interventions. Fantastic. Again, we need to be thinking cross-sectionally, interdisciplinary. There's some global competencies. On the right-hand side, that's to the, also has an HIV particular specific module. So you'll get these slides, and you can go ahead and tap into those and see more where you can focus your efforts. Next slide, please. In addition, leveraging the stigma reduction power of viral suppression, U equals U. This was also mentioned by Anne, a really great document that we can use to leverage the stigma reduction. I know my time is up, so I'll peruse through. Next slide, please. Almost done. And then finally, coming hopefully July or so, is a technical brief that WHO will be developing. We're trying to characterize stigma and discrimination and change the meaning, not the meaning, but the thought behind it as negative to positive. So our working title is Providing Good Quality Healthcare by Ensuring Dignity, Equity, Inclusion, and Reducing HIV-Related Stigma. And this brief is really to make those interventions that Anne referred to more concrete. So we're going to be talking about the principles and components of that happening and giving really good case examples and practical examples that could be adapted to different settings and synergizing across sectors, as I've mentioned. So stay tuned for that to come. Thanks, everyone. And if you have any questions or feedback or want to get in contact, please do so.
Thank you so much, Erica. Great and concise overview on WHO stigma-related guidance in the context of healthcare services and settings. From here, we now go actually into country practice exchange, and using a new modality for this key population community of practice sessions, we'll actually break into 3 different rooms. So in the main room, we will have an experience from Peru. In the breakout room 1, we will have an experience from Zimbabwe, and in breakout room 2, an experience from Jamaica. So please join one of the rooms. I think we'll give ourselves about 30 seconds to do that and then start the discussions. And there will be specific moderators in your breakout rooms. And you see the language instructions here, so please, interpretation will be in the main room. English, speakers can join the breakout rooms 1 and 2. And we have any confirmations on whether there are challenges with the splitting or whether everything is going smoothly?
Hi, Clemens, we can proceed in the main room.
We can proceed in the main room. Great, Karabo. So without further ado, I'll hand over to Mara Sumudio and Angela Villon from Peru to share their country experience and insights from Peru. So over to you, Farah and Angela.
Hola, buenos días. ¿Me pueden ver?
Todo bien, buenos días.
Mi cámara está desactivada. ¿Me la pueden activar?
La cámara no es activa, no es activada.
Bueno, entonces empezaré sin cámara. Bueno, en el Perú siempre ha habido mafias, siempre han existido policías, malos elementos policiales que han cobrado cupos, que se han organizado para delinquir, para hacernos violaciones sexuales sistemáticas. También habían mafias de malos peruanos que se dedicaban al cobro de cupos. Y esto sumado a las leyes criminalizantes que tenemos dentro del Código Penal, como por ejemplo la 179, que es de favorecimiento a la prostitución, en un país donde la prostitución no es delito. Esta ley es tirada de los pelos porque siempre ha sido como utilizada como un instrumento para el chantaje, para la extorsión, para las violaciones sexuales. Y no solamente esta ley que nos criminaliza, sino algunas otras leyes, como por ejemplo el de trata, donde especifica claramente todas las condiciones para que una persona sea víctima de trata. Sin embargo, también menciona la palabra prostitución, cuando los reales delitos es la trata de personas para explotación sexual, entre otros, ¿no? Igual sucede con el rufianismo. Entonces, nosotros tenemos ya las mafias desde antes, y esto ha permitido que el 99.9% de las intervenciones policiales sean para el chantaje, la extorsión y para la vulneración de derechos humanos. La segunda, por favor, diapositiva. El Perú tiene un número creciente y alarmante de homicidios y desapariciones, de secuestros, de parte de la mafia. Podría hacer una historia, ¿no? Que en el 2019 ingresaron personas que eran mandados por las mafias para que hicieran un mapeo y una investigación de las plazas, entre comillas, que son los lugares de trabajo sexual. Nosotras no teníamos muy claro qué era lo que estaba pasando, pero sí vimos cómo es que gente extranjera muy bien parecida empezaban a rondar por los lugares de trabajo sexual y se acercaban a los mafiosos peruanos, ¿no? A identificarlos. De repente, en el 2020 empezaron a asesinarlos, a asesinar a los mafiosos peruanos y a desplazarlos de los lugares de trabajo sexual de donde ellos ya venían cobrando cupo. Los empezaron a desplazar, las mafias extranjeras. En octubre del 2020, después de la pandemia, nosotros recibimos un primer mensaje de presentación de las mafias de malos extranjeros que llegaron al Perú a delinquir. Ellos se presentaban como una organización que iban a hacer, iban a ocupar las plazas, y que iban a recaudar fondos para hacer beneficios allá en su país. O sea, se presentaban como si fueran buenas personas, ¿no? Sin embargo, hubo una resistencia por parte de las trabajadoras sexuales peruanas de dejar estas plazas, y entonces empezó a haber mucha violencia. Tanto así que en febrero del 2022, asesinaron a 2 ecuatorianas en el centro de Lima que se rehusaron a pagar estas plazas. A partir de ahí, hubo recién un interés del gobierno de ocuparse de este tema, porque a pesar de que durante todo el tiempo nosotras vinimos denunciando este problema, ellos nunca nos hicieron caso y dejaron que las mafias se pudieran incrustar dentro de la ciudad de Lima. Es más, en estos mensajes ellos se presentaban y presentaban inclusive la estrategia que iban a utilizar, como por ejemplo que esto era como un plan piloto, esto de apropiarse de las plazas y del cobro de cupos, porque de ser así, este plan piloto, y de llevarse a cabo bien, se iba a extender a las regiones. Y esto se denunció y se dijo, pero se hizo caso omiso. En febrero del 2023 fue un inicio de una violencia extrema, porque si bien nosotras habíamos con las mafias peruanas sufrido de violencia, como por ejemplo cortes en la cara, o cortes en un seno, o cortes en un glúteo, nunca nos mataban. Y cuando empezaron a asesinar a las compañeras en el 2022, habían asesinado a gente víctimas de trata que ellos mismos habían traído. Sin embargo, en febrero del 2023, asesinaron de una manera tan violenta a nuestra compañera Rubí Ferrer y Priscila Aguado, pero ya con una cuestión de amedrentamiento que fue filmado, en el cual le propinaron 33 balas, y esto fue filmado y enviado a las redes del WhatsApp de ellas, entonces de ellas, pues, ¿no? Entonces nosotros lo recibimos, fue algo muy impresionante, de extrema violencia, y el cual nos causó mucho terror. El año 2022 lo cerramos con 35 desapariciones y 36 asesinatos. El 2023, que asesinaron a Rubí Ferrer y Priscila Aguado, cerramos con 41 desaparecidas y 32 asesinatos, ¿no? Las trabajadoras sexuales en estos momentos somos víctimas de violencia sexual, de torturas, asesinatos, secuestro, extorsión por parte de las mafias que han tomado el control, sobre todo de las calles céntricas de Lima y también en algunas regiones del país. Esos asesinatos tienen ahora este modus operandi, esta estrategia que han traído de filmarlos y pasarlos a los contactos de las víctimas. Esto ha traído como resultado que las trabajadoras sexuales no podamos seguir ejerciendo el trabajo sexual de una manera segura. Ahora no solamente las víctimas de trata son las que pagan cupos, sino también las peruanas. Igual todo el mundo paga, hay diferentes mafias, tenemos inclusive los mellizos que se suman a mafias peruanas con extranjeras que se han asociado. Entonces, eso ha traído precariedad, el Estado no nos asiste, vivimos en lo que nosotras llamamos en una vulnerabilidad extrema porque estamos en un país machista, misógino, judeocristiano, conservador, que no voltea a ver a las trabajadoras sexuales porque las considera ínfimas, y esto obviamente ha traído que se ponga en riesgo la adherencia al tratamiento antirretroviral de las personas que viven con VIH y que no se puedan acceder tampoco a los servicios relacionados con el VIH. Doy paso a mi compañera Farah.
Buenos días, buenos días. Sí, se me oye, ¿verdad? Se me oye, ¿verdad?
Buenos días. We
Sí,
can hear you.
bueno, si es que seguimos con las diapositivas, a mí me toca ver la parte o exponer la parte de qué cosa hemos hecho frente a esta violencia de género que se vivió en el Perú, cómo la abordamos. Bueno, lo primero que iniciamos fue con reubicaciones temporales para las mujeres trans y cis trabajadoras sexuales que han sido amenazadas por estas mafias de cobro de cupos, estas mafias de extorsión, ¿no? Como una especie de respuesta, las pudimos reubicar. eh, Primero se creó una situación, una comisión, un comité de dos mujeres trans y una mujer cisgénero que eran las que aprobaban estas reubicaciones, ¿no? Debido a las solicitudes que ellas presentaban, y en menos de 24 horas se podía dar respuesta para poder trasladar a estas personas que habían sido amenazadas o que habían tenido cualquier situación de peligro frente a estos extorsionadores, pudiendo así trasladarlas a sus lugares de orígenes o donde ellas decidan que estaban seguras. pudiendo así salvar la vida de las mujeres trabajadoras sexuales en el momento, ¿no? En esta acción de emergencia. Otra de las acciones que tomamos fue dar respuesta a la seguridad alimentaria de las mujeres trans, puesto que el contexto de violencia no las permitía trabajar, ¿no? Estaban siendo extorsionadas, estaban siendo violentadas. Entonces las mujeres trans que viven del día a día del trabajo sexual no podían tener recursos para poder alimentarse. Es así que con el Programa Mundial de Alimentos, como con otras organizaciones, pudimos brindar ayuda. Se brindó asistencia alimentaria para 60 mujeres trans en situación de necesidad de alimentos, ¿no? Y junto con el fondo de asistencia alimentaria que se implementó, pudimos ayudar a 10 personas, 5 mujeres trans y 5 mujeres cisgénero, que se encontraban en situación de desamparo que no podían trabajar, ¿no? También se brindó acompañamiento legal para las víctimas. Hola. También pudimos dar acompañamiento legal a las mujeres trans, ¿no? Y cis que fueron amenazadas, ¿no? De la mano con organizaciones aliadas que trabajan el tema legal. Asimismo, pudimos crear alianzas con Defensa Pública y el Ministerio de Justicia y Derechos Humanos de Perú para que pueda brindar acompañamiento a las denuncias. También realizamos recojo de información para poder presentar documentación a la CIDH, ¿no? Para poder presentar la solicitud de audiencia temática a la Corte Interamericana de Derechos Humanos, ¿no? De la mano con Sinergia y de la Red LAC Trans, ¿no? Así como con ONUCIDA. Eh, También pudimos conectar, unir o hacer el lazo entre las organizaciones que defendían derechos humanos de las mujeres trans con los fondos, con las organizaciones que brindan recursos de ayuda inmediata para poder acceder a fondos o dinero que las pudiera apoyar o recursos para que puedan ellas salir de esta emergencia y puedan ayudar a la población trans que se encontraba en peligro en ese momento. Como mencioné, hicimos la solicitud a la Corte Interamericana de Derechos Humanos para poder tener la audiencia temática, ¿no? Luego, creamos un informe para poder evidenciar la situación de las mujeres trabajadoras sexuales en estos últimos años y cómo había surgido este estallido de violencia hacia las mujeres trans. Siguiente diapositiva. En el siguiente, acá podemos ver las acciones de incidencia que pudimos realizar, ¿no? Pues, hicimos acciones de incidencia frente a las plazas, frente a instituciones gubernamentales, con la finalidad de que puedan accionar y puedan investigar las muertes y dar seguimiento a las denuncias de las compañeras, ¿no? Y de las familiares que clamaban justicia por sus muertas. Eh, Siguiente diapositiva. Eh, Luego, acá también podemos ver cómo pudimos brindar asistencia alimentaria para las mujeres trans que se encontraban en situación de necesidad y poder dar respuesta inmediata hacia la comida, el alimento diario, ¿no? Sí, podemos seguir. Eso fue con la ayuda de la OIM. ¿no? Y de otras organizaciones. Acá, esta son los números para poder seguir apoyando el fondo de emergencia. Debemos de tener en cuenta de que la situación no ha cambiado, el Estado no ha dado respuesta a nuestras demandas, sigue la situación de emergencia. Las compañeras trans siguen siendo amenazadas, las compañeras cisgénero siguen siendo violentadas, seguimos en la misma situación frente a ello. Hemos calmado el estallido de cierta forma, pero sigue siendo la extorsión una de las amenazas para las compañeras trabajadoras sexuales. Así es. Eh, Hago llamado para que puedan donar, y a la vez quisiera compartirles un video de un encuentro, una reunión de acuerpamiento que tuvimos las organizaciones trans. Entonces, eh, quisiera compartírselo y decirles que la resistencia continúa y que no somos víctimas pasivas y vamos a seguir buscando cómo apoyar a nuestra población.
Thank you so much for sharing this. And I think the video can be shared through a link with everyone. As you may have noted, we have taken the full time for hearing great experiences here in the main room from Peru, and I'm sure you had good discussions as well in the other sessions. If there are open questions to the presenters from those country experiences, please feel free to put them in the chat, because there was limited time for discussion. Without further ado, I think we can go from these experiences into the takeaways from this session. So what can really make a difference, and what can have an impact in reducing stigma experienced by key populations at scale, at country level? And we'll have reflections from different speakers, starting with Yuri Klimasevsky from the Ministry of Health in the Republic of Moldova. So Yuri will be speaking in Russian, so please switch to the translation that you need. Over to you, Yuri, in Chisinau.
Здравствуйте всем. Я очень внимательно слушал все презентации, очень интересный опыт, очень интересная информация. Значит, я очень коротко представлю что я подготовил. Значит, все, что касается прав человека, это, да, и дискриминация, но это должно иметь два таких компонента, да. Это первое, это правовая база со стороны государства, Министерства здравоохранения и так далее, ну, в зависимости от уровня, да. И второе, это мониторинг. Значит, вот в первой рубрике я хочу сказать, что у нас принят закон о равенстве, который дает право любому человеку обратиться и защитить свои права, вне зависимости от того, где или по какой причине ему это ущемили эти права. Да? И есть даже и механизм внедрения. Да? Есть комитет по равенству, куда любой человек, который считает, что его права были ущемлены в любой сфере, он может подать заявление, и его жалобу рассмотрят. У нас есть жалобы, которые были поданы представителями МСМ, да, мужчин, занимающихся с мужчинами, да, и одна из них даже была выиграна. Значит, потом есть закон о ВИЧ-СПИДе, который тоже очень, как бы говорится, черным по белому написано, что любая дискриминация связана с болезнью ВИЧ исключена и не должна быть допущена, и не только к ВИЧ-инфицированным, но и ко всем тем, кто имеет отношение к ВИЧ. Да? И Второе – это мониторинг. Значит, мониторинг, вот у нас есть установлено такое, значит, community lead monitoring. Это мониторинг представителями сообщества, потому что они заинтересованы в этом, и естественно, что этот мониторинг очень качественный, да, это и React, и другие моменты, которые мы разработали. Значит, все это мониторизируется, и каждый случай ущемления прав ВИЧ-инфицированного или члена семьи ВИЧ-инфицированного, значит, рассматривается и доводится до как бы логического конца, да, чем это закончилось. И мы считаем, что это очень такая хорошая модель, когда и на законодательном уровне было сделано, то есть принято законы, и мониторинг качественный, тем более от сообщества. Спасибо.
Спасибо большое. And really great insights on applying non-discrimination laws, and in addition, also community-led monitoring. And so with that, we can move to our next speaker, Arya Shabaspur from Impact, please.
Can you guys see? Can you hear me? Can everyone see and hear me?
We can hear you, Arya. Please, over to you.
Good morning, good afternoon, and good evening to all the colleagues. Thank you very much for this opportunity for me to share a few insights. I've listened to all the colleagues talking about different approaches to addressing stigma, and it is very enlightening and eye-opening. And I thought maybe by sharing a few insights, I can give you the perspective of impact and a few words from the key population. When we talk about stigma, it is very important to understand that we cannot begin to address the stigma without acknowledging that the stigma is constructed. And nearly 7 countries around the world criminalize same-sex behaviors. And the laws in Ghana and Uganda and Russia strive to make all aspects of the LGBTQ people and their lives criminal. Homophobic and transphobic policies and attitudes foster violence and discrimination. And as a result, when we talk about addressing stigma in key populations, first we need to recognize the bigger issue that our community is facing around the world, and that is the basic right to exist. And in the present social and psychological, social and political climate, where trans individuals are being banned from public places like parks in Iran, or when we see new anti-LGBT legislations coming from Ghana and Africa, it is very difficult to address the stigma when their whole existence is under attack. Pushes the population to reside in hiding in fear of their safety, and consequently creates a more hostile environment. And we cannot begin to address the stigma in its full, let's say, capacity. I remember personally, as a gay man living in Iran, the paralyzing fear of discovery, the paralyzing fear of stigma, it stops you from reaching, and it stops you from exploring, it stops you from participating in the society. And when we talk about constructed, when we say stigma is constructed, what does that even mean? When we talk about stigma in a context of individuals, it is very easy to narrow it down and to say one person is facing stigma. What can we do to stop that from happening? But I urge you to look at the bigger picture and to wider your perspective as why the stigma, how does the stigma is structured, and is structured by who? Usually when we talk about stigma is structured by governments, by religion, by culture, by institutions. And there are 2 ways of looking at stigma: from the bottoms up, which is that individuals, their experiences, and it's about the top down, like what can we do to change the structure as a whole that ensures that these individuals will not be subjected to the same things when we move forward. We say constructed, the perspective needs to change. And the way forward, I suggest usually what matters is visibility, representation, because when these individuals that are all facing the same stigma, then they connect and they realize they're all facing the same thing. And this creates the community. When there's representation, there's visibility, there's community, this empowers the population to take action, to be more proactive, to participate, and it as a result reduce the stigma. When we come to reducing stigma in any form of setting, it can be humanitarian program, projects, preventions, inclusion. The first step would be to educate and advocate for the rights of the key population, because education and accountability ensures LGBTQI individuals are safe when they're accessing healthcare or HIV services, and accountability for those who perpetrate discrimination. So when we talk about the population, when we talk about their rights, it's important to mention that at the climate that there are a lot of investments in governments and policies that criminalize the population, there should be equally and comparably investments in our community, because the investments means affirmation of the LGBTQI lives. By encouraging and empowering the population itself to take control of the narratives and actively participate in programs, where first of all, it will ensure the successful implementation of these stigma reduction programs. And secondly, it will provide an inclusive atmosphere that ensures the population's engagement and consequently success of the stigma reduction campaigns. So providing safe spaces for LGBT people, not just in the regards to HIV treatments or prevention, but ensuring that they actively participate in their community and have a good quality of life. I don't want to take more time of the colleagues. I thank you very much for this opportunity, and I hope these insights were useful. Thank you.
Thank you so much. Indeed, very useful practical insights on stigma reduction campaigns from a community perspective. Over to you, Kent. Kent Clindera is with USAID, a major funder in the HIV response, for additional reflections.
Thanks, Clemens, and really happy to be with everyone today. This was wonderful. Thank you for putting this together. I really appreciated the diversity. I heard several things, and I think I always start when I talk about stigma. It's painful. 30 years into this epidemic, we're still struggling with stigma, but here we are. And especially as we look at key pops, it's something USAID is very keen and has been working on for a long time. I think I heard a few things that I want to reflect. First, this whole concept of internalized stigma, especially with key pops of internalized homophobia, transphobia, sex workers. We really need to invest more in building communities and helping folks be themselves. And it's a key piece USAID PEP works on. So that's a key thing I heard, and we need to continue it. I also heard U equals U, and I think we finally have some data. U equals U actually is a stigma reduction tool. And so it's something, just left our big Asia regional meeting with PEPFAR, where U equals U was being mentioned in every country. And I think it's something KPOP should take on and something we should be promoting. I appreciated the focus on KP-led CSOs and their role, and UNAIDS goals around the 30, 80, 60% of programming that's delivered by women and K-pop-led. It's a key piece. I'm actually here in Botswana, actually focused on this right now, about how we can scale up, directly fund some KP-led CSOs here. And then finally, I think, it's about hearts and minds. And I think I asked a question about legal reform and how we're measuring that. But I think it's very much about, impacting hearts and minds. And when I work with key pops and I walk, I was in Glenroy's breakout, and just the work done with government in Jamaica, that's how it's going to change. And so I appreciate all the work that KP leaders are doing, how we can, UNAIDS supporting this. It's a very impressive show today. So thank you.
Thank you so much, Kent. And yeah, important reflections and great work happening in terms of also taking the community-led, and in this case, key population-led response forward in addressing stigma, but also prevention and other elements of the response. I will not try to summarize because we have gone beyond our time, but clearly the important next steps. This is a space of collaboration between the Prevention Coalition and the prevention implementers, human rights activists, and community-led organizations. And with all these ideas that we have heard today at country level, there's actually an opportunity to come together in a similar way. People working on scale programs, prevention programs, people working on advocacy come together and see how these actions and these evidence-based interventions that we've seen in the guidelines can be integrated into scaled national HIV responses so that we reach actually a significant or large enough number in line with our global targets of key populations and key populations in leading roles in the response to address stigma as part of the HIV prevention and broader HIV response programs. With that, I wish you a great rest of the day and look forward to future discussions. And next session of the Key Population Community of Practice will be held on a related topic, enabling laws for HIV prevention in relation to key populations. And that session will happen around the AIDS conference in Munich and be another webinar that you can join, or if you're in Munich, you might even want to drop in the actual session. So thanks so much and looking forward to continue engaging.
Thanks so much, everyone.